Welcome to the online class on fungal infection. I am Dr. G.K. Verma, Associate Professor, Department of Dermatology, IGMC Shimla. Today we will discuss introduction about fungal infections, then how we classify different fungi and their infection. The fungal infection are divided into superficial fungal infection, subcutaneous fungal infection, and systemic fungal infection. Today we will be covering superficial fungal infection. That will be pityriasis versicolor, tinea nigra, pydra, dermatophytosis. And in next class I will be taking candidiasis, subcutaneous fungal infections including mycetoma, chromoblastomycosis, sporotrichosis, then systemic fungal infection which includes histoplasmosis, blastomycosis, systemic candidiasis. First of all, we should know what is mycology. Mycology is a branch of science which deals with the study of fungal infections. Fungi in nature, they are omnipresent. More than 70,000 species are present in nature. They may be in the soil, they may be on plants, water and air. So the fungi is present in abundance in nature. And more than 300 recognized species are pathogenic, and these pathogenic species, they cause fungal diseases, that is mycosis, in human and animals. Earliest record regarding the mycotic infection in our country date back to 2000 to 1000 BC in Atharvaveda, where foot mycetoma was described under the name of foot anthill. Then another term which we will be dealing in fungal infection, that is tinea. This was used by Romans for the lesions of tinea, for the lesions of fungal infection, and the tinea is a Roman word which means small insect larva. Initially they thought that these diseases or these fungal infections are caused by small insect larva, which is not true. So another term which we will be using, that is favus, which is again Latin word which means honeycomb. It is basically a chronic fungal infection of scalp hair and was first human mycosis where the causative fungi was identified, and it was dermatophyte which causes this condition. Then about various clinical picture of fungal infection. Fungi, they can involve our superficial part of skin, subcutaneous tissue, and they can involve deep tissue, that is deep mycosis, or internal organs can be involved. So we divide into three parts. That when the fungi involves fully keratinized tissue, that is stratum corneum, hair and nail, then it is known as superficial fungal infection. When the fungi penetrate deeper into the skin up to dermis and subcutaneous tissue level, then it is subcutaneous fungal infections. When the fungal elements, they infect internal organs of the body along with skin, then it is deep mycosis. In superficial mycosis, the cutaneous presentation depends upon the inflammation in the lesions. If there are two kinds of inflammatory lesions in the skin because of superficial mycosis. When there is minimal inflammation or no inflammation, then it is caused by either pityriasis versicolor, tinea nigra, black pydra, or white pydra. And the pathogens which are responsible for these lesions which have no inflammation or minimal inflammation, they are Malassezia furfur or Malassezia globosa causing pityriasis versicolor, then Hortia wernicki causing tinea nigra, and Pydra horti causing black pydra, and Trichosporon bigali causing white pydra. Then when the lesions, they are inflammatory, they are red, then the causative agents are trichophyton, microsporum, epidermophyton, and this is all these three, they constitute dermatophytic infections of skin in the form of tinea capitis, tinea barbi, tinea fasciae, tinea corporis, tinea cruris, tinea manum, and tinea pedis. And then another superficial mycosis is cutaneous candidiasis, which is most commonly caused by Candida albicans, but other non-Candida albicans species are now coming up. And the one important thing which we should note here, that these non-Candida albicans species are sometimes resistant to commonly used antifungals. Now coming to predisposing factors for fungal infections. Tropical climate, where the climate is hot, humid, the chances of fungal infections are more. Then people who are involved in manual labor, manual work, and who are socio-economically weaker, who have more sweaty skin, they are more prone to fungal infections. Then friction with clothes, when synthetic innerwears are there, they cause friction. Then penetration of the fungus is more, and maceration and humidity and sweating is more, then more chances of fungal infection is there. Then in host factors, malnutrition of the patient is also important, and immunosuppressed state of the patient is also important. Anybody who is suffering from HIV, diabetes, malignancy, congenital immunodeficiencies, or patients who are on immunosuppressive drugs like corticosteroids, methotrexate, cyclosporin, azathioprine. There are a number of immunosuppressive drugs which are commonly used for various other diseases. They also predispose individuals or patients to fungal infections. Now coming to one by one in detail with various fungal infections, superficial fungal infections. First of all, we will deal with pityriasis versicolor. As the name suggests, versicolor means variable colors. The lesions in this fungal infection can be hypopigmented or they can be hyperpigmentation. This fungal infection is very common. Around 50% of population in tropics is involved, and 2% in temperate regions have this fungal infection. And this is caused by Malassezia furfur, which is a lipophilic yeast. And it is important to note here that it is a common commensal in our skin. So when the colonization with this fungal element is increased, then it clinically presents as a disease. Normally this fungi, it resides in keratin of skin at puberty and thereafter. So youth with oily and sweaty skin with overgrowth of normal flora of Malassezia furfur, they have clinical picture of pityriasis versicolor, which is multiple discrete discolored macules with brown like scaling, and the color can be brown to pink in hyperpigmented type and gray to whitish in hypopigmented type. The lesions, they are pinhead size to small large sheets of discoloration, and the common area which is involved, that is seborrheic area, upper trunk and shoulder and arm. Less frequently face, especially in children, scalp, antecubital fossa, submammary region can also be involved along with groin. When only flexors are involved, but no other area is involved, then the clinical picture is different. So it is known as inverse pityriasis versicolor. As we already discussed that the color, there are two types of color. Either hypopigmentation is there, which is because of inhibitory effect of azelaic acid. This is an acid which is secreted by the fungus. This acid inhibits the tyrosinase in melanocyte, causing hypopigmentation of the skin, and whereas hyperpigmentation is due to hyperkeratosis of the skin, that is thickening of the skin, scaling in the skin. In this we have bran like fine scales over the lesions. Then when we confirm our clinical diagnosis, we need to confirm this fungi with KOH preparation, and we also do Wood's lamp examination. On Wood's lamp examination, blue, green, yellow fluorescence is seen. I'll be showing you a picture of that. And when we prepared KOH slide, then spaghetti and meatball appearance is typical of this fungal infection, in which coarse mycelial fragmented to short filaments of 2 to 5 micron wide and up to 2 to 5 micron long, together with spherical and thick walled yeast, which is 2 to 8 micron in diameter, is arranged in grape like fashion. Another Indian name for this condition is orange with bananas. This is a clinical picture of a patient which shows multiple discrete to confluent hypopigmented lesions, hypopigmented macules and patches with fine brain-like scale on the lesions on the back of the patient. And in this picture we see hyperpigmented macular lesions with scaling in the patient on the trunk. And here hypopigmented pituitary versicolor in submemory area. And this is a picture of Wood's lamp examination, where we can see the fluorescence by which we can the clue goes in favor of pituitary versicolor. Then KOH mount. In KOH mount we can see these small dot like things which are yeast form, and these mycelial form, this constituting spaghetti and meatball, which is specific for this fungal infection in the diagnosis. Then this is another picture in which mycelial form can be seen and spores can be seen in spaghetti and meatball appearance. Then in histopathology, although usually we do not require histopathology for this superficial fungal infection because the diagnosis is clinical, so we do not need any confirmation, but if histopathology is done, then we can see where the fungus resides. It is present in stratum corneum. We can see these small lesions, small areas, rounded areas. They are spores, they are yeast form, and the long elements, they are mycelial form. So these are fungal elements in stratum corneum. Then another disease which is caused by this malassezia is Pituitary folliculitis. Usually teenagers and young adults, they are the sufferers, and clinically it is pruritic, excoriated monomorphic follicular papules and pustules scattered over the shoulder and back. This condition we have to differentiate from common cutaneous disease, that is acne vulgaris, because acne also involved back of a patient, but in acne we do not have any pruritus, but in this condition the lesions, they are intensely pruritic. And another differentiating point is comedone formation. In acne the comedone is a primary lesion, but whereas in Pituitary folliculitis there will be absence of comedones. So these are two differentiating points between Pituitary folliculitis and acne vulgaris. But ultimately we can do KOH examination where only yeast forms are seen, no hyphal form is seen, and then we can differentiate this disease from acne by doing KOH examination. This is a clinical picture where papulopustular lesions are seen over the upper chest and upper back. They are discrete and they are intensely itchy. So no comedone is seen. So it is Pituitary folliculitis. Then another superficial fungal infection, which is Tinea nigra. Although this is uncommon, we rarely see any patient in ROPD. As we see plenty of patients with tinea versicolor or Pituitary folliculitis, this tinea nigra is less common or rare fungal infection. This is caused by a pigmented fungus, which is Exophila wernicki. This fungus comes from decaying vegetation, wood or soil, and clinically there can be single or multiple sharply marginated brown to grey-green patch which may be velvety, or mild scaling may be there, and usually they are asymptomatic, and they are commonly are on palms or sole, and they resemble clinically silver nitrate stain. This is a clinical picture. You can see on the palms there is brownish patch with no scaling, and it is asymptomatic. Again, another clinical picture with brownish patch over palm. This is Tinea nigra palmaris. Then another superficial fungal infection of hair shaft. which is known as pidra. Clinically, it can be in the form of white pidra or black pidra, and the causative organism, they are also different, and the clinical picture is also different. In white pidra, the nodular lesion, we have nodular lesion on the shaft of the hair, and the nodule in white pidra will be white. Occasionally it may be red, green or light brown, but in black pidra it is brown to black. The firmness of the nodule is soft in white pidra, whereas it is hard in black pidra, and nodule adherence to the shaft is loose in white pidra and it is hard in black pidra. And the typical anatomical location of the this fungal infection is face, axilla and pubic area in white pidra, and occasionally scalp hair can also be involved in white pidra. Black pidra, scalp and face hairs are commonly involved, whereas pubic hairs are rarely involved. We all know that it is a superficial fungal infection of hair shaft. The favored climate, again, for all the fungal infection, they are more in tropical areas. And for diagnosis, KOH examination of the crush, preparation of cut hair is done, and where we can see non-pigmented hyphae with blastoconidia and arthroconidia, whereas in black pidra the pigmented hyphae with asci and ascospores can be seen. Then culture on fungal culture media can be grown. In white pidra, the colonies, they are moist white colonies, creamy color colonies, whereas in black pidra the colonies, they are slow growing, dark green or dark brown, or they can be black colonies on fungal culture. Clinically, in this picture we can see black pidra and white pidra. In black pidra, firm nodules, hard nodules, they are on the hair shaft, whereas in white pidra, loosely adherent grayish to whitish nodular lesions, they are on the hair shaft. Then the most common clinical presentation of fungal infection which we encounter daily in our OPDs, and these days they are really troubling our patients. They are troubling even physicians, because resistance to these fungal infections is common to the common antifungal agents. So we are discussing these dermatophytes. These are fungal infections that invade and multiply with keratinized tissue, that is skin, hair and nail. So dermatophytosis include fungal infection of skin, hair and nail. Depending upon the mode of transmission or source of infection, they can be anthrophilic, zoophilic or geophilic. Anthrophilic means when the infection, it comes from one human to another human, and typical clinical picture is either there will be no inflammation or there will be mild inflammation, and the infections, they are chronic. And the causative fungi which are responsible for anthrophilic fungal infection, they are Trichophyton rubrum, Trichophyton tonsillan, Trichophyton concentricum, Trichophyton mentogrophyte, variety interdigital, and Epidermophyton flocosum. These are the common dermatophytic genus which are responsible for anthrophilic fungal infection. Then zoophilic, when the infection comes from animal to human, because there is change in the host, so inflammation in the host will be intense. The lesions, they are pustular, vesicular, and they are acute lesions. Intensely red lesions will be there. So clinically we can differentiate whether they are zoophilic or they are anthrophilic or they are geophilic to some extent. And the etiological agents in zoophilic fungal infections, they are Trichophyton mentogrophyte, then Microsporum canis and Trichophyton verrucosum. Then geophilic, when the fungal element, they come from soil to human or animals. And here also the lesions are inflammatory, but the inflammation is moderate. It is not very intense or minimal, it is moderate. And the causative fungi is Microsporum gypsum. So now coming to the pathogenesis, how these fungal elements, they cause a disease in a host. When a host come in contact with fungal spores or fungal elements, then the fungal elements, they adhere to the host, where the host factors are predisposing for this infection, as we have already discussed. After adherence, these fungal elements, they secrete keratinases, which facilitate the invasion of fungus into the stratum corneum and causes disease in the stratum corneum. It may be nail, it may be hair, or it may be skin. But the penetration is not deep because there are inhibitory factors, serum factors, that is transferrin levels in serum, which is responsible for inhibition of fungal penetration deeper into the skin. So deep involvement is not there in the superficial fungal infection. But these fungi, they contain mannins and beta globulins, which are responsible for virulence of these superficial fungal infections. Then we will discuss various terminology which are commonly discussed in dermatophytosis. That is tinea capitis, when head, skin and hair is involved. Then tinea faciae, when face is involved. Then when beard area is involved, then it is known as tinea barbae. Then trunk and body, tinea corporis. Groin and gluteal fold, tinea cruris. When palm is involved, then tinea menum. And sole, tinea pedis. When nails are involved, then it is tinea unguum. So depending upon the site of infection, there are various terms for this superficial fungal infection, that is dermatophytosis or ringworm. Then we will cover one by one. Tinea corporis is first. It is a dermatophytosis of the trunk and extremities with the exclusion of palms. When palms are involved, then we call tinea menum, and in exclusion of soles, then tinea pedis, and exclusion of groin when it is tinea cruris. Incubation period, it may range from 1 week to 3 weeks, and all species of dermatophytes can cause it. But the commonest species which is responsible for this tinea corporis is tinea rubrum, then followed by tinea mentogorphyte, then microsporum canis. But epidemiology is changing, as these days when we send fungal culture from our patients to mycology lab, then we see that now the trends are changing. It is not rubrum now, it is tinea mentogorphyte, which is upcoming fungus in our state, although previously it was tinea rubrum. Why it is known as ringworm? Now we can see the ring shaped plaques in tinea corporis, where we can see the outer ring, which is active part of the lesion, which keep on eating the fungus, keep on eating the keratin and keep on spreading away from the center. And at the center part where keratin is lost and the immunity is improved, and there is clearing of the skin, and so there is peripheral extension of the lesion and they become annular or ring shaped. That's why sometime commonly it is known as ringworm. Then tinea corporis, continue. Then morphologically it can be acute, arcuate, circinate or oval, as we have discussed or seen in the picture. And then there are some special clinical variants of tinea corporis, that is tinea profunda, Majocchi's granuloma, tinea imbricata, multiple subcutaneous cysts caused by Trichophyton rubrum and presumably associated with immunocompromised state. This is tinea profundum. Here we can see that there is large lesion, nodular lesion with granulomatous change. So it is basically granulomatous perifolliculitis of skin. You can see here a mustache area is involved, and beard, it can extend to the beard area also. So intense inflammation is there, large boggy swelling is there. So when see such kind of lesion, we should also think of tinea profunda. Then another picture where we can see follicular abscesses with granuloma formation over the neck. These are discrete abscess like lesion with follicular granulomas, known as Majocchi's granuloma. Commonly they are treated as bacterial infection, but they do not respond to antibiotics. Then ultimately diagnosis is confirmed by fungal culture or KOH preparation, and then it turns out to be Majocchi's granuloma, so which is a fungal infection. The other site for this Majocchi's granuloma is legs. Then another picture, another type of clinical variant of Tinea corporis is Tinea imbricata, which is caused by Trichophyton concentricum. We can see multiple concentric rings in this picture, which is typical of Tinea imbricata. And sometime when topical steroids are used for treatment of the tinea, then this kind of picture can be there, which is pseudotinea imbricata, which is not caused by Trichophyton concentricum. It can be that can be caused by Trichophyton rubrum or Trichophyton mentogrophyte, but clinically, if steroids are used, the picture is altered, and pictures are altered, and it looks like to be Tinea imbricata. Then classical Tinea corporis, in this picture we can see peripheral extension, large annular plaques with scaling at the center, and healing at the center also, and peripheral ring like structure is there, and peripheral extension is there. And here we can see recalcitrant eczematized Tinea corporis, right? So there must be some wrong treatment with steroid, or there may be no treatment at all, so lesion becomes recalcitrant and eczematized. Then how to differentiate Tinea corporis from other commonly seen cutaneous dermatosis? These dermatosis may be nummular eczema, patellar type of seborrheic dermatitis, pityriasis rosea, erythema annulare, subacute lupus erythematosus, granuloma annulare, or annular pustulosis, annular psoriasis. So these are common dermatoses where we have to differentiate them from Tinea corporis. Here we can see the typical lesion of nummular eczema, which is not a fungal infection, but sometimes it is wrongly treated as fungal infection. There is no improvement or mild improvement initially, but ultimately the lesion they are there, and we can see the vesiculation as well as wetness and crusted annular coin-shaped lesions in nummular eczema. So we should keep in mind these differential diagnoses, and we should make our clinical diagnosis clear. The another condition is seborrheic dermatitis. We can see the seborrheic areas they are involved. Axilla and front of chest is involved, and it is a patellar type of seborrheic dermatitis. So it can be confused with Tinea corporis. So KOH examination gives the clue and the sites involved, and bilaterally symmetrical. So it is a endogenous eczema. It is not a fungal infection. The next condition is pityriasis rosea. In pityriasis rosea, we see the lesions, they are commonly on the back, and they are arranged in inverted fir tree appearance, and they are along the these lines, body lines, and they give typical appearance. And sometimes some larger lesions which are called a herald patch, they can be there in pityriasis rosea, and usually they are asymptomatic, but sometimes they can be pruritic. So it is common differential diagnosis which is not a fungal infection. Then granuloma annulare, we can see annular lesion of granuloma annulare, but the difference from Tinea corporis is that there is no epidermal change, there is no skilling, the lesion is deep down in the dermis. So we should think of granuloma annulare in such patients. Again, this is a granuloma annulare, second patient, annular lesions with no epidermal change, but the lesions, they are tinea like. KOH will be negative, so we should keep this condition also in mind when we deal with Tinea corporis. Again, psoriasis, common dermatosis, papilloscomus dermatosis, where annular lesion can also be there, and they can be confused with tinea lesions, right? Then when this kind of annular lesion in a patient with numbness or lesions, they are on the trunk, and there is anhidrosis, loss of appendages is there, insensitivity is there, then we should think of borderline lepromatous leprosy. So sometimes it may be difficult to differentiate leprosy from tinea corporis. Again, leprosy lesion. Then another condition, erythema annulare centrifugum, which has to be differentiated from tinea corporis by doing KOH. Right, KOH examination will be negative. Then another common dermatosis, that is sarcoidosis, in which we can have annular lesions, but the sites they are around eyes, and if KOH examination is done, that is negative, and we can see symmetrical involvement. Usually in infections they do not have symmetrical involvement, whereas other dermatosis they can have they have usually symmetrical involvement. So this is again differentiating point. Then lichen planus, in which purple colored annular lesions can be seen. Again, there is minimal scaling or epidermal change, so more dermal involvement is there. So the color is purple, so we have to differentiate it again from tinea corporis. Again, SLE patient, subacute cutaneous LE, where annular lesions are, papillosquamous annular lesions are there. So for common physician, it may be tinea corporis, but it is not tinea corporis, it is SLE, cutaneous LE, subcutaneous LE. Then another presentation of dermatophyte infection is tinea cruris, where the inguinal region is involved. There is area of erythema and pruritus in folds between scrotum and inner thigh, characterized by sharply demarcated and raised erythematous scaly advancing border, and may contain pustules and vesicle at the periphery. So folds are involved in tinea cruris, gluteal folds, and groin is involved. And tinea menum, hands are involved, and this condition has to be differentiated from hand dermatitis or palmar psoriasis. As we talk about dermatic infections, so they are usually unilateral. So when lesions are unilateral, scaly, then we have to do KOH to differentiate it from other dermatoses, and the KOH will be positive, so it is tinea menum. It has two varieties. One is non-inflammatory, the lesions they are dry, scaly, mildly itchy, but in other variety where inflammation is more, the lesion may be vesicular or red or itchy. Then another clinical picture of tinea faciae. Tinea faciae, when face is involved, usually we use this term tinea faciae for female patients, children, and when facial skin where beard is not there, then it is known as tinea faciae, but when this area is involved, then it is known as tinea barbi. So it is just different names for the same infection. So the lesion, they are erythematous, scaly, patch, they can be annular, circinate, or induration will be there, pustulation at borders can be there, they are intensely itchy. When patient expose themselves to the sun, then intense itching can be there. So sometimes confused with skin allergy because of sun, that means PMLE, polymorphous light eruption, which is a common type of sun allergy we see in our patients. So it can be confused with tinea faciae or tinea barbi, commonly seen in immunocompromised patients. Another patient of tinea barbi or tinea faciae, then as we have already discussed, when beard area is involved, then it is known as tinea barbi. And in tinea barbi, the lesions, they can be different to some extent, because when hair follicles are involved, then pustular folliculitis is the clinical picture, and commonly caused by zoophilic fungus, and highly inflammatory lesions can be there, and these hair and mustache area, hair of the beard and mustache area is involved with pustules and papules, with oozing of pus and crusting, and the hair, they are easily pluckable, and sometimes there may be complication in the form of abscess formation, sinus tract formation, bacterial super infection, Kirion like boggy swelling, and ultimately there can be hair loss. So alopecia can be result if they are not properly diagnose and properly treat it. So we have to differentiate this fungal infection from psychosis Barbie, which is again misnomer. Psychosis Barbie, sometimes some people think it is fungal infection. It is not fungal infection, it is defolliculitis caused by Staph aureus. Then acne lesions can be similar, so we have to differentiate tinea Barbie from acne vulgaris, and then we have to differentiate it from pseudofolliculitis, which is because of ingrown hair in the skin. This is tinea Barbie. We can see follicular pustules, right? Inflammation is there, and these follicular pustules, sometimes wrongly treated with antibiotics, there is no response. They have to be treated with antifungals, topical as well as oral, and then they get cured. Then another type of tinea infection, which is very common infection in children, and another important thing of this fungal infection in children, there can be epidemic of tinea capitis, because it is when seen in children, then it can be present in their siblings as well as in their classmates. So we should always, when we see a patient of hair loss, a child with hair loss, then we should first, clinical suspicion should be tinea capitis. So infection of scalp hair is there. Commonest mycosis observed in children, caused by dermatophytes in the genera Mycosporum and Trichophyton. Epidermophyton is not traditionally isolated from tinea capitis. So it is important to remember here that epidermophyton usually do not cause tinea capitis, whereas two other important genera, that is Mycosporum and Trichophyton, are more responsible for tinea capitis. When we talk about epidemiology in American continent, Trichophyton tonsorine is the most common causative agent, whereas in European countries it is Trichophyton solanae and Mycosporum canis, whereas in Asia or India it is Trichophyton volaceum, which is the most common agent responsible for tinea capitis. So epidemiology is changing. And then clinical types, it can be non-inflammatory or it can be inflammatory. When inflammation is not there, then the clinical picture can be in the form of gray patch or in the form of black dot. We will be discussing in detail in further slides. And in inflammatory form, there can be favors. Another presentation can be in the form of carrion. One thing which we should remember, which is very important to remember here, whenever we have inflammatory tinea capitis, there is usually scarring alopecia. That means permanent hair loss will be there. So it has to be diagnosed early, correctly, and has to be managed properly so that hair loss can be controlled. Otherwise, there will be permanent hair loss for life. Again, we have to differentiate these children on the pattern of invasion. There can be endothrix pattern, ectothrix pattern, and favus. In endothrix, the infection with anthrophilic fungi by non-fluorescent Anthraconadia within the hair shaft, because the causative fungi that is inside the hair shaft, and because of that the hair shaft becomes very fragile, and the hair shaft will break at the cutaneous level only. So we will show you the slide where black dot type of clinical picture is because of endothrix pattern of invasion of fungal elements, and commonly caused by Trichophyton tonsorine and Trichophyton volaceum. Whereas ectothrix means the infection is from outside. The outside of hair shaft is covered with Anthraconadia, and fluorescent and non-fluorescent both type of picture can be there when we do Wood's lamp examination. Then favus is another type where hyphae and air spaces within the hair shaft are seen, and a blue-white fluorescence is seen on Wood's lamp examination. Then clinically, tinea capitis can present as gray patch, which is a commonest presentation, and caused by ectothrix pattern of invasion, and patches of partial hair loss are seen over the scalp, and they can be often circular, and numerous broken off hairs with dull gray and lusterless hair are seen due to overcoating of arthrospores, and they can cause epidemics in school. So any child coming to our OPD with hair loss with gray patch, we should always inquire family history. Any sibling in the family having tinea capitis, any classmate of that child, if he has similar lesion, they have to be treated simultaneously, otherwise the epidemic goes on. So etiological agent is Microsporum ordinary. The lesions they are usually asymptomatic, but mild itching can be there, but there is significant hair loss. In this picture we can see ectothrix, endothrix and favus. In ectothrix we can see the fungal elements, they are outside the hair shaft, and that gives a gray color, and in this the fungal element, they are inside the hair shaft, which make the hair too brittle, and the loss is at the surface, just above the surface of hair, so black dots will be seen clinically. Whereas in favus, which is caused by Trichophyton scholleniae, there are air spaces within the hair shaft, and that displays yellowish fluorescence in Wood's lamp examination, and bluish white fluorescence again because of these hair spaces. So causative agents are also different. In ectothrix there are microsporum species, then in endothrix they are Trichophyton tonsuran, Volatium, Pseudonae, rubrum. Rubrum is in both, although it is rare. So this is again clinical picture of KOH examination, KOH preparation, where we can see the center of the shaft is involved with the fungal elements, fungal spores. So this is gray patch. We can see small patches of hair loss with grayish discoloration, or mild scaling is there, and lusterless hair can be seen. So if it is not treated, then extensive hair loss can be there, and it spreads with to siblings and other classmates. And again in this picture we can see large circular areas over the scalp of grayish color with hair loss. Then black dot tinea capitis. Again we know that it is endothrix pattern of invasion. Hair shaft is brittle, break at the level of scalp. Remnant of the hair shaft left behind in the infected follicle appears as a black dot. That's why it is called black dot on clinical examination. Diffuse hair loss with minimal scaling and minimal inflammation is there. So these are small black dots where the hair shaft is broken, and we can see hair loss, again black spots. So it is endothrix type of invasion in tinea capitis. Again in this picture black dots are seen. You can appreciate these small black dots where the hair shaft is broken because of invasion of the fungal element in the center of the shaft. Then interesting type of tinea capitis, which is very rare, not very common, but when it is there, then it is dangerous, because it can cause hair loss for life, because the hair loss is scarring. So we should all know what is carry-on type of tinea capitis, and we should able to diagnose it properly and treat it properly, so that the child can have their normal hair growth. Mostly it is due to infection caused by Trichophyton verrucosum and Trichophyton mentogrophyte. Inflammatory boggy swelling with indurated tender swelling that is studied with broken hair or unbroken hair follicles with vesicular or pustular lesion, and sometimes when intense inflammation is there, then sinus formation or thick crusting with matted of the adjacent hair can be seen. And sometimes inflammation is very intense, then lymphadenopathy and secondary bacterial infection can be there. This is only clinical presentation of hair loss of tinea capitis, where we have to treat the patient with steroids as well as with antibiotics, because inflammation is intense, along with systemic antifungals. So it is very important to know its diagnosis, its clinical picture, its treatment. It heals with scarring, and sometimes e-direction can be there, autosensitization, autoexematization. The lesions can be all over the body. They can be on the trunk, they can be on the palms and soles, but they are because of secondary dissemination of the inflammation. It is not the fungus which goes to these sites. It is the inflammation or hypersensitivity caused by this severe inflammatory fungal infection, where a vesicular lesion can be seen on palm and soles, or anywhere on the body. So it is sometimes very grave condition. Then this is a clinical picture. We can see boggy swelling, which is erythematous, yellowish crust is there. Then these pustular lesions, pustules are there. If it is not treated properly, then whole of this rounded area becomes scar, and no hair will be there if it is not treated properly. So long oral antifungals, long duration oral antifungals, even for months, are to be given. If inflammation is more, even a short course of steroid or antibiotic, if evidence of secondary infection is there, is to be instituted. Again, boggy swelling with yellowish crust and whitish pustular lesions, although it is not that severe as it was previous. Then another rare tinea capitis, that is Favus, which is commonly seen in which is although very rare, but commonly seen in children of Kashmir in our country. It displays yellow cup-shaped crust composed of dense mat of mycelia and epithelial debris, which is called scutellum, shaped like a shield or shaped like a cup. These scutuli, they enlarge and merge to form prominent yellowish crust characterized by mousy odor. So smell is very bad. Borders of the infected lesion represent areas of advancing disease and often polycyclic in shape, and center of the infected area gradually becomes extensively scarred. So this was the another type of scarring alopecia, and almost devoid of hair. So it has to be treated properly, diagnosed properly, to avoid future complications of the scarring alopecia. Then commonest causative fungi is Trichophyton scholleniae. You can see the yellowish crust over the scalp and total hair loss, must not be diagnosed early and not treated properly. So scarring alopecia is there. Again, you can see these yellowish cup-shaped lesions of Favus, with characteristic smell is also there, because these are seen in patients who keep on using cap on their scalp. So it is important. Another tinea which commonly we see in ROPD, that is tinea pedis, when sole and dorsum of feet is involved, or interdigital area is involved, then it is known as tinea pedis. And clinically it can be interdigital, mosaican type, then in vesicular type, ulcerative type. In interdigital, the causative organisms, they are Trichophyton mentocophrite variety interdigital, Trichophyton rubrum, Epidermophyton flocosum. And clinically, this is the most common type of tinea pedis, and the lesions, they are erythematous, scaly, there can be fissuring and maceration. Sometime, although it is pruritic commonly, but sometime there can be pain because of the secondary infection. So when painful lesions are there, we should also give antibiotics, and just to treat secondary bacterial infection along with antifungals. Then second type is a Mocain type of tinea pedis, where diffuse hyperkeratotic erythematous lesions with scaling and fissuring is seen on one surface or both the surface. That means on the sole as well as the dorsum of the feet can be seen, and caused by Trichophyton rubrum and Epidermophyton flocosum. Again, these are the causative organism. Then vesicular tinea pedis, where the vesicle-like lesions can be there in tinea pedis, and bullous lesions can be there on the medial foot associated with again there can be e-direction in this condition, and causative organisms are trichophyton, mentagrophyte, and ulcerative last and severe form of tinea pedis is ulcerative tinea pedis caused by rubrum and mentagrophyte and E. floccosum. There is exacerbation of the interdigital tinea pedis that may ulcerate, and erosions can be there in the web space. Secondary infection can be there with the bacteria. Again, we have to, when we treat such patients, we have to give antibiotics, oral antibiotics as well as topical antibiotics along with antifungals. These are the clinical picture of interdigital, and where we can see all the web spaces they are involved, and here we can see macerated area, wet area, and commonly predisposition is also those who keep their feet wet, those who do not clean their feet regularly, then this can be the fungal infection, commonly is also called as athlete feet. Then fungal infection of nails. When we talk about fungal infection of nail, there are two terms which we have to differentiate. One is onychomycosis, another one is tinea unguum. Onychomycosis includes all fungal infections of nail. They may be dermatophytic, they may be non-dermatophytic. So it is a broader term, it is an umbrella term. And tinea unguum is a type of fungal infection of nail where only dermatophytes they invade the nail, and it is dermatophytic nail involvement. Dry, the lesions on the nail, the nails become dry, they becomes dull, they becomes yellowish, pitted, ridged, split, discolored, thick, uneven, and subungual hyperkeratosis can be there. And clinically they can be of four types: distal and lateral onychomycosis, proximal subungual onychomycosis, wide superficial onychomycosis, and total dystrophy of the nail. When it is there, then it is known as total dystrophic onychomycosis. So these are four types of clinical presentation of onychomycosis when nail involvement is there. But the most common is distal and lateral. And when proximal subonychomycosis and superficial white onychomycosis is seen, we should always suspect immunocompromised state. Either it can be HIV or it can be other immunocompromised state. These are some important clues for this. So the toenails, they are more commonly involved because toes, they are more prone to trauma. When traumatic nails are there, then the entry of the fungus is easier to the traumatic nails. And sometimes a patient comes to us, we tell them that it is fungal infection. They say it is not fungal infection, it is because of some trauma. So any traumatic injury to the nail predispose these nails to fungal infection. And men, they are more commonly involved, and trauma, as we already discussed, is important predisposing factor. And the most common pathogens, they are trichophyton rubrum, trichophyton mentagrophyte, and epidermophyton floccosum. And here we can see before treatment how destructive nail plate is there, and after oral antifungals, nail plate becomes good. So whenever we talk about the treatment of superficial fungal infection in dermatology, we treat fungal infection, any dermatological conditions, with two type of treatment, that is topical therapy and systemic therapy. In fungal infections, we give topical preparations of various antifungals. It may be triamazole cream, ketoconazole, muconazole, iconazole, sertaconazole, laliconazole. There are variety of topical antifungals which are to be given in topical fungal infection. But important thing is that the patient should apply these antifungal twice a day, and the application should be 2 cm away from the lesion, including 2 cm away from the lesion. So for this topical therapy we have rule of 2. That means 2 cm on the lesion as well as 2 cm away from the lesion, so that subclinical infection is also treated. And another factor of this rule of 2 is that it has to be continued 2 weeks more. If we see clinically, patient sees clinically that the treatment is over, the skin is fine, but we have to treat that normal looking skin even for 2 weeks more. So total elimination of the fungal element is there. In oral therapy, we give commonly these days we give itraconazole in the dose of 2 to 400 milligrams per day for 4 to 6 weeks, and then sometime we have to extend to many weeks, to many months. Another problem is the patient do not take regular treatment, so continuous therapy is also very important. Here terbinafine is given OD, that the dose is 200 to 500 milligram OD, and nowadays there is emergence of resistant to terbinafine, so itraconazole is commonly used drug, and we are also shifting to griseofulvin. The dose is 500 to 750 milligram per day. Although fluconazole is uncommonly used, it is commonly used for pityriasis versicolor only, not for other fungal infections. Then duration of treatment, as I have already told, that it is maximum for nail, that for months, and it is usually 4 to 6 weeks. But nowadays, as we are facing resistance in the treatment with the antifungal, so we have to extend the treatment to even 2 months to 3 months. So this was all about superficial fungal infection of today's class. Candidiasis I will be taking in next class. So if you have any queries, you can refer to your book, or you can ask me you can on your comments. Thank you for patience.